Mhm. Okay, Salil. Good afternoon, everybody. Today, we shall be discussing MRI interpretation. We'll start with few basic concepts of MRI. I won't be going to the technical aspects of the MRI procedure itself. I'll just touch upon the clinical aspects of MRI interpretation and some few important cases which we come across in day-to-day basis. So before going to the MRI proper, so I would like to discuss indications and contraindications. I mean, for example, for a clinician, you'll have to decide if you have to get a CT scan of the patient or an MRI. So even back then, when we had only CT, so we used to use CT for almost all the indications. But now MRI has been, I think, freely available, but still there are few places wherein MRI is still not freely available. So there are few indications and contraindications you should be knowing for every test. So MRI has few contraindications. So it has few downsides like it's going to take a long time, 30 to 45 minutes is required for the procedure of the MRI to be complete. So usually for children, you need sedation for that time. So sedation comes with all kinds of side effects and monitoring. So that is the biggest concern. So MRI is ideally not suitable in a PICU setup when the child is not stable enough, or if the child is on ventilator. So in that situation, it's not ideally suitable. Apart from that, you also have other contraindications like metallic implants, cardiac pacemakers, programmable VP shunts, and other metallic prosthetics like prosthetic valves. So these are few contraindications or relative contraindications wherein you have to inform the technician prior before you get an MRI. And coming to the indications, we don't have particular indications like do we have in CT. So in we prefer doing a CT brain whenever we have suspected intracranial bleed or calcification in an acute trauma setup. But in MRI, the indications are pretty broad, taking from neonatal encephalopathy to developmental delay, neuroregression, evaluation of a seizure, first episode of unprovoked seizure, and characterizing epilepsy to rule out structural epilepsies, in a suspected intracranial tumor, in a suspected stroke, in a suspected cerebral venous sinus thrombosis. The indications are pretty wide in pediatric neurology. So whenever you feel that the cause is likely the central nervous system, it is logical to get an MRI for etiology as well as for localization. So before you interpret the MRI well, and you should definitely know the neuroanatomy perfectly, so that you should be able to identify the normal anatomy, so that you will be able to rightly pick up the abnormal anatomy you see. And especially that holds true for blood supply. You have to know the details of all the branches of the circle of Willis, which you have read in your undergrad. And also differentiation of various deep nuclei, that is basal ganglion. You'll have to know the anatomy of basal ganglion very in detail. And also you need to correlate this anatomic abnormalities which you see on MRI. Try to correlate with your patient in a setup wherein you have, for example, the same findings which you see in MRI can be seen in other conditions. So the clinical context is very extremely important when you actually interpret an MRI. So we'll talk about a few pathological aspects as well, how to actually interpret MRI and try to find a hypothesis for it. And this is the most important thing I think everybody is looking out for. I think you need to identify the sequences and the cuts of the MRI very well. And the classic neuroradiological signs of few common entities will be discussed because this is a very huge topic. I think I'll only cover a few aspects of it. So how to interpret an MRI scan? So how to decode an MRI scan? So as I said, I mean, most of the clinicians actually completely rely on the radiologist's report. So that actually comes with few downsides because you know the exact clinical context and you know exactly where to look at. So I think just not go by the report of the radiologist. I think try to interpret whatever you see with your patient and clinical context. And would you definitely ask why was it advised? And is it the patient was in the ICU setup wherein the child needed an emergency MRI for which treatment is still pending, or you want to do MRI for an evaluation? So the context is extremely important. And if you find any abnormality in one section or one cut, don't just stop there and make a diagnosis right away. So try and be patient and see all the cuts and sequences to form a hypothesis. I mean, for example, if you see T2 or flare hyperintensity, just go back and see the same area. Is it involved in diffusion restriction? Maybe try to hypothesize that this is probably an ongoing process rather than an old process. For example, if you have some finding wherein you have T2 hyperintensity, go back and see the SWI images wherein it could be an old bleed. So try and see all the sequences as possible, and never forget to see sagittal and coronal views also, because you'll miss some findings wherein axial cuts won't give that information. And this is, I mean, this you'll develop this over time. I mean, the lesions which you see or the abnormalities which you see in MRI, do they have some specific signature of a pathology? That is very important. So topography, for example, I have a patient who has acute onset movement disorder, and the MRI showed only a deep nuclear changes, hyperintensity in the caudate and lentiform nucleus. So this topography is very important. I'll probably hypothesize that there is some metabolic disorder which is affecting basal ganglion only. So it is symmetric or asymmetric. So that's where the patient has movement disorder. So the topography, is it involving only deep nuclei? Is it involving only subcortical matter or white matter? Is it involving only cortical, or is it involving only brainstem, only cerebellum? It's extremely important. So in the clinical context, for example, if I have a child with neuroregression and I have only findings in the white matter, so I would probably think of a leukodystrophy. So the topography and the pattern recognition is extremely important in neurology. And as I said, I mean, you need to correlate various findings you see on MRI with other sequences. And also, when you see an MRI, I mean, try seeing the MRI when it's actually being done. And you can also order for any special sequences if required at the same moment. For example, if you see diffusion restriction in a particular territory in an artery, for example, MCA, you have a large MCA infarct, which is showing, T2 hyperintensity and flare hyperintensities. So you think it is an MCA infarct, you just talk to the radiologist and say that, I need an angiogram right away. So like that. So, for example, you have a patient with headache and subacute onset headache and vomitings and posterior fossa signs, and you got an MRI done, and you see this child has some ixol, that is a tumor seen in the posterior fossa. I mean, if you're right at this time wherein the MRI has been done, so at the same setting, you can actually ask the radiologist to get an MR spectro or a contrast sequence to add on. So, I mean, the additional request, what you do, what you ask to a radiologist is also important. That is, routinely, we don't do an angio or immuno or SWI is routinely done, but MR spectro, these are all special add-ons, which, depends on case to case basis. And at the end of the whole thing, I mean, why was the MRI ordered, and what was the indication, and what is the complete clinical context? I mean, what are you actually looking from that perspective, from the clinical perspective and the radiological perspective, with additional sequences and additional imaging, and formulate a hypothesis. For example, I had a child with acute onset hemiplegia. The MRI showed T2 hypointensity in the MCA territory, which also had diffusion restriction. Then I went ahead with MR angio, which also showed there is an occlusion in the MCA artery. So that actually kind of formulates a hypothesis. It explains the whole story, so that if you be very clear with the etiology, then only you'll treat well. So that is formulating hypothesis is extremely important. So coming to the basic differences, what you have between CT and MRI. So if you see the resolution of the brain parenchyma or the structure of the brain is extremely high with MRI. So in most of the conditions, MRI is extremely superior. When you actually see the structural anatomy, the lobar anatomy, everything is at higher resolution with MRI when you compare to CT. CT gives you basic information about uh, very gross things like, the advantage of CT is out of this spectrum of stocks. So even in this era wherein MRI is very freely available, CT is still the first investigation of choice in an unstable patient or a TBI, traumatic brain injury, wherein you're suspecting a bleed or a calcification. CT is still more sensitive than MRI, though we have special sequences in MRI to detect those. So if you see here in the picture, So the resolution of the parenchyma is extremely high with MRI. As you can see, differentiate between the cortex, the subcortical white matter, and you can clearly see the gyri and sulcations. You can see the falx, you can see the dural folds. You can see also differentiate clearly the deep nuclei. This is caudate, this is multiform nucleus, this is the thalami. And the lobar differentiation of the structural anatomy is extremely high with MRI with different sequences. Whereas if you see here, the CT again, you see the bony architecture is clearly seen here with the and CT. And apart from that, the structure of the brain is not that clear. You get basic information here. So here the basic differences you have to remember. If you're suspecting a bleed or a calcification or an acute thing which you want to see, for example, if the child is suddenly has develops an anisocoria, you want to rule out herniation syndromes, and the patient is not stable, you can get a CT. So you'll get enough information from the CT itself. And also in CT, the term which we use, for example, we use the term densities, that is hypodense or hyperdense in CT. When compared to, when compared to MRI, we use the term hypointense and hyperintense. So these are the basic differences, and CT takes very less time. MRI takes usually 30 to 45 minutes of time. And CT has radiation exposure, MRI does not have radiation exposure. Okay, coming to the MRI basics, I think this is the most important slide. When you actually interpret an MRI, you have to differentiate these three primary sequences. These are the extremely important ones. The first one is T1. So how do you identify T1? T1, remember the mnemonic, T1 is an anatomical sequence. Here you have white matter looks white, the gray matter looks gray, okay, as the anatomy goes. Whereas in T2, you have the opposite of it. Your white matter appears more dark than the gray matter, and the CSF is white. Okay, so the mnemonic here is the World War II, that is W and 2. That is water is white in T2. So just remember World War II, that is water is white in T2. That is the CSF is white, if you see here. And the gray matter is gray and the white matter is darker, so opposite of the T1. And flare is exactly same as T2 with the subtraction of the white CSF. So the whiteness is been removed with flare. So you see the entire image is same as a T2, but flare has the CSF being suppressed. So flare actually stands that. Okay, flare is basically the fluid is attenuated. Okay, these are the three main sequences you see in the basic scans of MRI. Apart from this, this is an extremely important sequence which I think most of you actually don't look for. I think in a neurology setup, I think diffusion restriction is extremely important in acute neurology setup, especially in ICU, neonatal ICUs, or PICU. So here, the concept of diffusion restriction actually came in the context of stroke patients in adults, wherein the changes of stroke actually takes time. And if you see the golden hour, that is the thrombolytics need to be administered within 4 hours of 4 to 6 hours of stroke. So by the time the signs on the T2 and flare develop, actually the golden hour is actually gone. So that's when people actually thought that no, we should have a new sequence which is actually more sensitive for acute changes. And diffusion restriction actually came in that context for adult stroke. So diffusion restriction, it picks up ischemic changes or energy restriction. So for example, any pathology which has energy failure, that is, there is cellular energy failure. For example, there is a metabolic disorder or a mitochondrial dysfunction, or there is a glutaric aciduria, or there is any sort of acute small molecule disorder wherein the cell actually has the energy failure. So that is also picked up on diffusion restriction. So this is extremely important for a pediatric neurologist point of view and pediatrician, because in a suspected small molecule IEM, inborn errors of metabolism like organic acidemias or mitochondrial disorders or lay spectrum, you actually see a diffusion restriction. That means there is an acute decompensation of the ongoing inborn error of metabolism. So whenever you see a diffusion restriction, you see the pattern where which part is involved. And the same part when you have the hyper intensity on DWI, the same part you have to cross check it on ADC. ADC actually is apparent diffusion quotient. So it's like the evil sister of DWI. So wherever you have DWI changes, the exact same region should have corresponding changes on ADC, and then that becomes significant. And you say that that particular area is called diffusion restriction. So whenever you interpret and say that, you say that no, there is this part of the brain is showing DWI changes with corresponding changes on ADC, suggestive of diffusion restriction. So for example, on DWI, if you see a large MCA territory diffusion restriction, you have to see the same area on ADC. And that will show dark ADC question loss of signal. So that is, you see the dark area on ADC and bright area on DWI. That means there is diffusion restriction. So that means the child has acute stroke of MCA territory, okay, which has happened recently. So the diffusion restriction actually gives you clue that there is some energy failure happening in few days. So there is 5 to 6 days. This still picks up diffusion restriction. Okay. Then next thing you have to know when you specifically ask the radiologist that, in a setting of an infection, if you're suspecting a CNS infection or a meningitis, or if you're suspecting an inflammatory granuloma or intracranial tumor, you specifically ask for the radiologist to give contrast. So this is a contrast enhanced MRI sequence. You see there's leptomeningeal, you see this is the take of the contrast. So it is very important to know that these are the normal areas which are taking up contrast. So this should not be confused with leptomeningeal enhancement. So leptomeningeal enhancement looks even more profound. You see that the contrast enhancement goes all the way into the sulci. This is a normal contrast enhancement when compared to leptomeningeal enhancement. So this is a patient who has actually a meningitis. You see, apart from the normal MCA branches which are going, the contrast enhancement is all the way inside the pachymeninges. You see in the deep sulci, there is contrast enhancement, there is pachymeningitis. So this is probably meningitis and this is normal. Okay, so in the right situation, it's important to ask for a contrast enhanced sequence for the radiologist when you're suspecting an infection or an inflammatory granuloma or an ICSOL or a few other conditions wherein you are expected to have contrast enhancement. All right, so these are some of the sequences. I'll introduce you another sequence which is also important. So this is called SWI. Okay, this is susceptibility weighted image or GRE images. These sequences were specifically made to pick up bleeds, old bleeds. So if there is hemosiderin deposition, for example, a child at 3 years is seizing and you get an MRI done. And in SWI, you see a signal loss in the ventricular region. So this means that there is some old bleed which has happened long back. So in the setting of a ventricular bleed, a child, so this probably indicates that the child had IVH during his preterm delivery time. So perinatal event can be picked up, or any sort of old bleed will be picked up on SWI. So this is also an important sequence. This is an example of an SWI sequence showing signal losses. So this is called blooming artifact. So that means this signal is not able to be taken up. So that actually is shown like this. So this means there is some sort of hemosiderin deposition indicating that there is an old bleed. So this is SWI image. Okay, so to revise, I have discussed about T1, T2, flare, DWI, ADC, and then contrast images and SWI images. Okay, these are the most important sequences. This is also SWI image showing various old bleeds. So this is signal loss or hypointensity, what you see. This is suggestive of old bleeds. Okay, so now coming to the cuts. So the most common cut which we get on MRI sequence, all these sequences were axial images. Okay, so this is actually the sagittal cut. So wherein you see some structures very prominent here. So this anatomy also needs to be very important. So, so few structures like corpus callosum, the limbic, the corpus, this is the cingulate gyrus, the frontal lobe, especially the brainstem anatomy, cerebellum. You can see these structures very clearly on a sagittal image. Excuse me. So on sagittal, you also look at the structure of cerebellum, the brainstem orientation, and the structure of corpus callosum. So this view is also important to identify few structures. So what do you identify here? What is this section on the left side? And what is the section on the right side? The section on the left side is sagittal image, wherein you can see cerebellar atrophy. So in the setup of a child presenting with telangiectasia, this is a case of ataxia telangiectasia. So you see the cerebellar atrophy being very clear on the sagittal images. When compared to right, this is the same patient on the axial. There is prominent cerebellar folia. So sometimes it gets very difficult to actually to comment on cerebellar atrophy on an axial image. So we need to get to compare and see on the sagittal image. So this is another sequence. This is another cut which is called coronal cut. So in this cut, you see specifically look for temporal lobe. So this is the temporal lobe, the hippocampus. So when you're suspecting medial temporal lobe sclerosis or hippocampal sclerosis or DNATs or any sort of tumors in the temporal lobe, you actually go and specifically look for this cut. This is called the coronal cut. So you have axial cuts, you have sagittal cuts, and this is coronal cut. So this is a patient who had hippocampal sclerosis on the left side. You can see that there's left-sided T2 flare hyperintensities. So this is suggestive of MTS, that is medial temporal sclerosis on the coronal cut. So what do you see in this patient? If I take this image, what is the sequence and what is the cut? So if you're thinking the cut is the axial one, then what is the sequence? See the CSF is black here. So this is probably a flare sequence. And what do you see in this patient? You see there are T2 and flare hyperintensities here. So these are fluffy infiltrates. So if you just see this image, this actually looks like ADEM, but this is vasogenic edema. So if you actually, after a few days, this patient was again subjected to have MRA and you see these lesions. So this child actually had an inflammatory granuloma, probably neurocystic cirrhosis. So this was perilesional edema. So it's important that sometimes you may have to repeat the MRA also. In the acute stages, we cannot see the inflammatory granuloma because it's covered with perilesional edema. Okay, this is another special add-on when you actually suspect any metabolic disorder. So MR spectro is a very important tool for a pediatric neurologist. So different diseases which have MR spectro signature. For example, so it's basically MR spectro tells you what kind of chemical is elevated in the particular region of the brain. So there are various peaks on MR spectro, like choline peak, creatine peak, Na peak, etc. So in different disorders, there is an abnormal peak in different disorders. For example, if I have a patient with focal onset seizure and the MRI revealed an inflammation granuloma, and you have various differentiating features of neurocystic sarcosis and tuberculoma, but you still have some sort of confusion whether it's neurocystic sarcosis or tuberculoma because the treatment is completely different. So in that particular situation, we can actually get an MR spectro done because we know that tuberculoma will have a lipid peak. Okay, so tuberculoma, as you know, the Mycobacterium tuberculosis has mycolic acid, which is a lipid. So you'll have a lipid peak. So lipid peak is suggestive of few disorders. In the same way, there's a disorder called Canavan disease, wherein you have NAAB. Okay, that is also diagnostic. So in some disorders, you have different peaks. So in the setup of pediatric neurology, if the patient comes to you with autism spectrum disorder with a regression at later onset, like 3 to 5 years, you suspect creatine transporter defect. So in that, you have negative creatine peak. So you don't have the normal creatine peak, you have a very low creatine peak. So in this way, there are different peaks in different situations which can actually help you in diagnosing. So we have to specifically ask the radiologist to do a spectrum in which part of the body, to in the white matter or the basal ganglion, and ask for it. Or in the setup of a brain tumor, whenever you have ICSOL identified, sometimes the different tumors will have different peaks. So in that situation also you can get an MR spectro done. Another special add-on to your MRI when you're suspecting uh, cerebral vascular event or a stroke, specifically in children who came to you with acute hemiplegia. or you are strongly suspecting that it's vascular or acute onset event which has happened, then order for MR angio. In MR angio, again, you have to look for the structure of the circle of Willis. If you see, this is, if you see from the down, so these are, what are these arteries? These are called vertebral arteries. They join together and form basilar artery. Basilar artery divides into posterior cerebrals. And from here, there is internal carotid artery, which is coming and it gives branches of MCA, which is going perpendicularly to the right and left. And these are ACAs. So this is the circle of Willis. You need to identify the anatomy of circle of Willis and also observe for any abnormal pathology. If there is any blocks or any loss of signals. So that indicates that there's probably occlusion or a thrombus in that particular area. So when you're suspecting an acute ischemic event, then also ask for MR angio in the same setting. So you need to be well aware of all the anatomy of different branches, what you see in circular Willis. So a quick review, these are two vertebrals. Vertebrals actually come from which part of the body? Vertebrals come from the second part of subclavian artery. So from vertebrals actually ascend up, two vertebrals together form your basilar artery. Then basilar artery gives fountain branches and labyrinthine artery and ICA, and then gives terminal branches of posterior cerebral arteries. Okay. So this is the posterior circulation, which comes from behind. So remember posterior circulation and anterior circulation. And anterior circulation is formed by your internal carotid artery. It comes from common carotid. Common carotid comes from the arch of aorta. And internal carotid artery goes into your carotid canal, enters into the intracranial fossa, and then it divides into two branches. That is anterior cerebral artery and MCA, that is middle cerebral artery. Both the anterior cerebral arteries are communicated by anterior communicating artery, right? The MCAs go perpendicularly. So this is the left MCA, this is the right MCA. And the anterior circulation completes by this. The anterior communication and the posterior circulation are communicated by this communicating branch. This is called posterior communicating artery. So this forms a circular Willis. For example, there's a block here. So this entire part can be collaterally be supplied for this by the posterior circulation. So this communication is basically to ensure that if there is block in some artery, the circulation takes care of it. So this is in short the circulation, the circular Willis. We have to know the anatomy so that you'll identify it on the picture of MR angio. So the MR angio picture is not going to be this clear. So you have to know your structural anatomy very well so that you need to identify the normal anatomy and then the pathology. Then on the brain MRI, you need to also know the MRI of various arterial territories. So this is the axial cut. When you see this is the pink zone is actually showing your MCA territory, and the yellow one is showing your ACA territory, and this blue one is the PCA territory. So you have to know the territories wherein you have to identify the probable arterial territory being involved. So another special add-on to your MRI, whenever you're suspecting that your child has a venous sinus thrombosis, that is CVST, cerebral venous sinus thrombosis, you have to ask for MR venogram in addition to the regular sequences. So in a setting of an acute headache or subacute onset headache in a child with a known thrombophilia or a condition which actually predisposes with CVST like nephrotic syndrome or a cyanotic congenital heart disease. So you suspect that this child is highly prone to have CVST, then you can actually proactively ask for an MR venogram. So again, here basic structures. This is superior sagittal sinus. This is the inferior sagittal sinus. This is the vein of Galen. And here you have the straight sinus. Then you have transverse sinus, sigmoid sinus, confluence of sinuses, and it will all drain into internal jugular vein. So you have to know the basic veins we have to be able to identify on the venogram. And then only you'll be able to find the abnormality. In this picture, what do you see abnormal? So this is an MR venogram or arteriogram. So this is MR venogram, as you know. So do you see anything abnormal? So in the left, if you're thinking that in the left image actually has some sort of occlusion or loss of signal here, the transverse sinus. So there's actually a block. So this is a transverse sinus thrombosis. What do you see here? Again, MR veno actually showing a large thrombus spanning across the superior sagittal sinus. Okay, so this is also the case of CVST. Okay, to summarize, you have all these sequences, that is T1, T2, flare, that you need to identify. These are the basic sequences. Apart from that, you have DWI images with must be correlated with ADC, and the cuts you have to specifically see all the axial sections and then look at the sagittal sections and coronal sections. And if you're suspecting an ischemia, order for an MR angiogram. If you're suspecting some venous obstructions, you can also get an venogram. And if you're specifically looking for some any metabolic disorder or an XSOL, you can order for an MR spectroscopy. So these are some extra. So coming to the anatomy, what you see here on an axial cut. So this is extremely important to identify because there are a lot of pediatric neurological conditions which specifically involve specific part of deep nuclei. So here I've tried to show in the light blue color, this is the corpus callosum. This is the anterior part, that's called genu. So remember, genu is shown in the blue color. This orange color is the splenium of corpus callosum. So these are the two parts of corpus callosum. Genu, body, and the splenium. What you see here in blue is putamen. This is putamen. What you see in green, this is thalamus. And this is caudate nucleus. These are the most important structures you need to identify because in different types of encephalitis, we have different parts being involved. In different metabolic disorders, different parts are involved. Okay, let's discuss this in detail. Few conditions, I think before going to few conditions, you have to know your neuroanatomy well. So I won't go into the anatomy now. So these are the various types of cells. This is the blood-brain barrier. These are different types of cerebral edema. So from the MRI, you should be probably able to diagnose what type of edema we are dealing with because it has treatment implications. For example, in a case of an XSOL or a large tumor or a large inflammatory granule, the surrounding area actually is swollen. So that is called the vasogenic cerebral edema. That happens because there is disruption of blood-brain barrier. So that is actually vasogenic edema. So in that condition, there's a role of steroids. In vasogenic edema, there's a role of steroids. And cytotoxic cerebral edema, as I said, it is actually because of cellular metabolic failure. So energy failure causes cytotoxic cerebral edema. This is seen in metabolic disorders, small molecule metabolic disorders, and ischemic stroke. So here, there's no role of steroids. And the third type of edema, what I'm talking about, is the interstitial cerebral edema. So this is basically the leakage of the blood, the leakage of the CSF from the ventricles into the parenchyma. So basically, there's high pressure in the ventricles. There is seepage of CSF. So that is interstitial edema. So there is a role of acetazolamide here. Okay, so that is important in identifying which different types of edemas you have. And based on that, you can actually try for, the therapies depend on that. And osmolar cerebral edema is seen in osmotic demyelination syndromes. Okay, these are the various types of edemas. I think you know the basic anatomy of pleural layers, and you have to know this because you have to see which type of bleed is it, where is the deposition, where is the electromagnetic enhancement, and all that. I won't go into the details of this. Okay, so we'll come to a few cases. So this is a child who has come to me with 2 days history of fever and acute onset encephalopathy. The child's disease is very low and have gotten MRA. What do you see? So if you see what sequence is this, first of all, the CSF is dark. Okay, and this is a flare image because the white matter is dark. The CSF is dark. So this is a flare axial image showing there is bilateral hyperintensities in the thalami. So there is symmetric hyperintensity and swollen thalami showing bilateral thalamic involvement. So this, where do you see this? And you also see there is cerebellar involvement and there's also brainstem being involved. So this picture is typically seen in few infections like dengue encephalitis and also in a condition called ANEC, that is acute necrotizing encephalitis of childhood. So here the diagnosing that is very important because the treatment is completely different. So this is ANEC with the typical trilaminar sign is in diffusion restriction. This is another patient has come to me with 2 days of fever and acute encephalopathy and seizures. So here you see diffuse asymmetric fluffy shadows on T2 because this is CSF is white. So there's a T2 image. So these are all fluffy finger-like projections of cotton wool-like lesions, asymmetric, large. So this is a typical feature which is seen in ADEM, that is acute demyelinating encephalomyelitis. Okay, so this is ADEM, a very important para-infectious disorder that's seen in children following triple URI or any infection. They're present with hyperacute or acute onset encephalopathy with seizures. And they dramatically respond to the methylpred, and that is steroids. And you need to get few antibody tests done for this. So here is another child who has come to me, a 7-year-old child with fever and URTI, and also has this mild encephalitis for which I got an MRI done, which showed this. So this is the sequence, what the sequence is. So actually it looks like the CSF is dark, so it should be T1 or flare, okay? And the white matter is actually dark, so it should be flare. Or there's another clue here. We see this white hyperdensities. This is actually a DWI image. This should be correlated with ADC. But what you see on DWI, there is some hyperintensity here. So this is what part of the brain is it? This is the splenium. So there is some diffusion restriction in the splenium. This is actually a radiological diagnosis. This is called MERS. Okay, MERS is basically mild encephalitis with restricted diffusion of splenium. This is also called as restless in adults. There are few viral infections which specifically involve the splenium of corpus callosum. So this is called MERS. It can also be caused by COVID, like Epstein-Barr, mycoplasma, etc. So this is MERS. Okay, what do you see here? There's another child who has come to me with a 7-year-old boy came to me with focal onset seizures. This child had right focal seizures with twitching of eye and right-sided hand movements. And I got an MRI done. What do you see here? If you see here again, there is hyperintensity in the left temporal region. So there is definitely a component of encephalitis. So encephalitis with temporal involvement, I would think of herpes encephalitis. So this child had herpes encephalitis. There's another child who has come to me with history of 4 days history of altered sensorium and irritability, and also 2-3 episodes of focal seizures. Again, here there is predominant involvement of temporal lobes. So this picture is also seen in herpes encephalitis. If you see here again, temporal lobe is enhanced. So unilateral or bilateral involvement of temporal lobe, always think of herpes encephalitis. This is an 8-year-old child who has come to me with symptoms of right-sided focal seizure and altered sensorium. And this child had history of some exanthemus lesions 6 days back. The child had fever and some sort of rash. They're not exactly able to describe what rash is it. And after that, this child had this type of presentation with MRI. So what do you think? So what do you see here? There is the left-sided picture is diffusion restriction. There is diffusion restriction in the caudate and lentiform nucleus, and also in the thalamus, right? And if you see the same regions, the T2 has hyperintensities in the thalamus, caudate, and lentiform. So here, what I'm trying to say is basically, you see the clinical context. This child had fever and rash. So there's some exanthemus fever in the past, in the 7 days back, and now the child has presented to you with focal seizures. Okay, there's something happening. The clinical context actually tells that there's some para-infectious or post-infectious phenomenon happening, right? And in the MRI, you see some diffusion restriction happening. So that means diffusion restriction, there is an active or an acute thing which is happening. And the topography, actually, if you see, there is one side involvement. So whenever you have acute onset, one side being involved, always think of vascular thing. So here, and if you see the topography, caudate, lentiform, thalamus, they are all supplied by the lenticular striate vessel. So this is the topographic hypothesis what I made. So again, you can confirm that I got an MRI angio, and you can actually see that there is some occlusion in the MCA. So near the region of M1. So here, because M1 is blocked, so you have probably lenticular striate actually also being involved. This is a stroke which is seen after a viral infection. So the most common infection when children you have post-infectious stroke is varicella. This is post-varicella vasculopathy involving MCA and lenticular striate vessels, causing basal ganglia stroke, which shows diffusion restriction and T2 hyperintensity. Okay, so there is definitely a role of steroids and acyclovir in this condition. So this is how you make hypothesis from the clinical context and various sequences on MRI. So in this type of approach, so there are different viral infections with different type of topography. So basically, you'll have to know about neurotropic viruses. So neurotropic viruses actually love CNS, but you also have to know which part is more susceptible for which type of infection. As we already discussed, herpes simplex actually has temporal lobe involvement, and there are few infections like varicella zoster, Epstein-Barr, even mumps virus. They predominantly tend to involve your deep nuclei, that is chordate and lentiform nucleus. And there are few rare infections like rotavirus and human paracovirus. They involve deep white matter. So this is a common infection seen in neonatal infections. Okay, they involve only the white matter. And coming to brainstem and the spinal cord, you have to think of enteroviruses. And other viruses can cause predominantly your cerebellum involvement, especially varicella is also known to cause cerebellitis. So varicella, Epstein-Barr, mycoplasma are known to cause cerebellitis. And the myelitis pattern, that is basically the major involvement being brainstem and spinal cord. Again, think of enteroviruses. Okay, enterovirus, poliovirus can be thought of. Okay, these are the different topographies or neurotrophs of different viruses having specific pattern of the encephalitis. Another case, this child has come to me with at 3 months of age with acute onset history of seizures and development, no neck folding yet. So what do you see here in the MRI? So also look at different sequences, try to identify the sequence, also see if there are any focal hyperintensities, but also look at the basic structural anatomy of the brain. If you see there are no sulcations and gyrations of this brain. So when we have smooth brains, this is a patient with listen carefully. Okay. So this coronal we have already discussed. So these are the in neonatal setup, whenever you're thinking of a hypoxic event or a hypoglycemia or a neonatal encephalopathy, when you actually get an MRI, you should be aware of these three patterns. So when there is a sudden, when there is neonatal ischemia, so when there is history of delayed cry or there is history of resuscitation which is happening, so you have to know the different patterns. So there is a mild pattern of neonatal ischemia, which causes watershed type of pattern. That is ACA and MCA, the gap between ACA. So this is a watershed here, and this is a watershed between MCA and PCA. So here you have diffusion restriction and T2 hyperintensities. When you have sudden and profound ischemia, for example, the mother had placental abruption or cord around the neck, like sudden cutoff of the blood supply. So in that type of picture, you have this pattern called BGT, that is basal ganglion and thalamus. So here you have diffusion restriction and T2 hyperintensity and deep nuclear and thalamus. So BGT stands for basal ganglion and thalamus. Okay. And the third one is there is profound ischemia and for a long time. So this is called global pattern, wherein you'll have combination of both watershed and BGT, and all the parts of the brain are involved. These are the three patterns of hypoxic ischemic encephalopathy. So apart from this is another neonate presenting at 8 days of life with acute onset neonatal encephalopathy, who suddenly started having a refusal to feed and vomitings from day 4 as soon as the feeds were started. So this is which neonatal condition? So whenever you're thinking of a neonatal condition presenting in the first week of life, it should be a small molecule disorder, that is organic acidemias or organoacidopathies, aminoacidopathies, or any other small molecule disorder. So this is the typical picture. What you see is basically there is myelin splitting edema. So these are the early myelinating structures. You see, this is a motor strip. This is the motor cortex, and this is the plic, posterior limb of internal capsule, and these are occipital radiations, and this is cerebellum, dentate nucleus. So, and the midbrain, the brainstem. These are all the early myelinating structures. All of them are swollen, and they show diffusion restriction. So whenever this picture is there in MRI, you think of MSUD, that is maple syrup urine disease. So this is a MRI pattern recognition or radiological diagnosis. You stop the baby on fields, they'll improve, and we can get a metabolic testing to confirm. So there are different patterns of various metabolic disorders. So this is also important in diagnosing for pattern recognitions. So this is another MRI of a child who has come to me with history of acute encephalopathy. and seizures. So what do you see here again? So this is a multiple neurocysticercosis you see. Okay, so this is another example. So in the setup of pediatric AES, again, the different patterns, this is actually called the double donut sign. So this pattern is quite similar to what you see in ANIC, that is acute necrotizing encephalitis of childhood. Same pattern can be seen in dengue encephalitis also. So dengue encephalitis also has thalamic involvement, brainstem involvement, cerebellar involvement. But the typical trilaminar sign is seen in ANIC, whereas you see double donut sign in dengue encephalitis. Okay, this is another child with dengue encephalitis. What do you see here? This child has come to me with the history of left-sided focal seizures. So this is a clue, and the seizures were continuous and they're not stopping. What do you think in this disorder? So if you see here, there is some asymmetry between the cerebral hemispheres. So left looks normal, the right looks atrophic. So whenever you have one hemisphere being involved, you think of conditions like Rasmussen's encephalitis, Sturge-Weber syndrome, hemimegalencephaly like that. So when you have specific atrophy of all these lesions, all these structures like caudate nucleus is also atrophic. There is enlargement of the frontal horn. There is atrophy of the cerebral hemisphere. You think of Rasmussen's encephalitis. But this is a child with Rasmussen's encephalitis. They're present with prolonged seizures. So that is called epilepsia partialis continua. So we have focal seizures that are continuously going on. And it is important to diagnose because it's a radiological diagnosis and they respond dramatically to steroids. This is about Rasmussen's encephalitis. Clinically, you have to have a high suspicion whenever you have a prolonged and refractive partial seizures or epilepsia partialis continua, and then get promptly neuroimaging on time, and you can start immunotherapy right away. Okay, this is another child who has come to me with history of 3 days of seizures and onset of encephalopathy in the last 24 hours. I got an MRI done. This we have already discussed. They are fluffy, large shadows of T2 hyperintensities, and they're involving asymmetrically. So this is a demyelination, obviously. So this is ADEM, common in children again. So whenever we have a demyelination, suspected demyelination, so these lesions, if you see the hyperintensities along the ventricle, so this is characteristic of MS, and this is characteristic of MOGAD or ADEM. So any type of demyelination when you're suspecting, always look for orbital cuts. You look for optic neuritis and also screen for spine. So because ADEM can have spine involvement like transverse myelitis and also multiple sclerosis and also neuromyelitis optica. The entire spectrum of demyelination, whenever you're thinking, get specific cuts of orbits to look for optic neuritis or sheath edema, and definitely screen the whole spine to look for transverse myelitis. So this patient also had a large longitudinally extensive transverse myelitis. So this is the important clue in diagnosis. So this actually helps you in diagnosing which type of demyelination you are dealing with and also the management protocols. So here, what do you see? This is another child who has come to me with history of 3 days of encephalopathy and have got an MRI done. There's no history of fever in this child. So this was suggestive of a T2 hyperintensity, and it was a huge mass-like structure. And this child went to the neurosurgeon, and they thought it was a tumor and has been removed. And the tumor was sent for biopsy, histopathological examination, which showed actually lymphocytic infiltration. So this is actually not a tumor. This is tumefactive demyelination. So this is often misdiagnosed as tumors. So it's a radiological diagnosis. Always think of tumefactive demyelination in a setup of a large T2 hyperintensity like that with vasogenic edema. It's a very close differential diagnosis for a glioma. So these are various pattern recognitions in different metabolic disorders. So this type of pattern recognition is also important in pediatric metabolic disorders. So you should be aware of these patterns. These are all patterns in acute drug ingestion. So this is less common when compared to metabolic disorders. So the pattern recognition is also extremely important. I won't go into the details of this. So this is another patient who has come to me with history of vomitings, and the child was admitted. The child had severe hyponatremia. And after 2 days, the child had very low GC. So what do you think? Here, this is This is the brainstem. In the midbrain, you see these signs. There is hyperintensity, T2 hyperintensity seen in the brainstem in the cross section. So this is osmotic demyelination syndrome. So you have specific signs of osmotic demyelination syndrome. So this is the big nose sign or big snoot sign, or this is the trident sign. So these are few signs seen in osmotic demyelination syndrome. So here I have another patient who has come to me with the 1 year history of neuroregression, cognitive decline, and also new onset movement disorder since last 3 months. So I was thinking of a metabolic disorder which causes movement disorder. I have screened for serum ceruloplasmin, which came to be normal, and I've got an MRI. This is a picture. So here you see this is a T2 sequence because the CSF is wide, and T2 hypointensity. So if you see GP, that is globus pallidus, hypointensity in T2, so that means there is some deposition. So this is a determinant. Whenever you have T2 hypointensity, hypo is low intensity on T2, that means in that region there is some paramagnetic substance deposition. So here, with the history of neuroregression and movement disorder and T2 hypointensity, I would think of iron deposition. So this is neuronal brain iron deposition. So this is NBI spectrum. And if you see there is a hyperintensity in the center, it looks like an eye of a tiger. So this is an eye of a tiger sign seen in PCAN, that is pantothenate kinase associated neurodegeneration, previously called Halliburton spots. So this is another child with the NBI spectrum, wherein you see T2 hypointensities in bilateral symmetric globus pallidus. Okay, this is another child who has come to me with a history of 4 days of encephalopathy. This child is around 5 years, and there's no prior history of any other fever or anything like that. So whenever you have an afebrile patient coming to you with acute features of hyperintensities in bilateral symmetric basal ganglia, think of metabolic disorders, especially mitochondrial disorders will cause this type of picture. So this is actually a lay-like presentation. You see T2 and flare hyperintensities in bilateral caudate nucleus and lentiform nucleus. The entire lentiform nucleus is swollen. So this probably indicates that there is a metabolic disorder. Or in a setup of fever, then this pattern can also be seen in encephalitis. Okay, what you see here, this is a neonate coming to me with history of extensive thrust. So this when you would try to actually do burping for this child has extensive thrust, and this child had neonatal history of jaundice. That is, his hyperbil was around 24, and this child received exchange transfusion. So what is a likely diagnosis? What do you see here? Here you see flare hyperintensity in the GP. Okay, so then whenever you have a neonatal history and you have GP hyperintensity, think of connectors, that is bind, bilirubin-induced neurological dysfunction. So in that clinical correlation, you have dystonia, extensive thrust, and you have sensory near hearing loss and subtle delay. So these are the various forms and based on the severity. So if there's a mild bind, mild hyperbil, you have this. So this when progresses to have this severe form of bind. So here I have a child who has come to me at 8 years of age with history of seizures, sudden onset seizures. And this child told me that before the seizure, the child has loss of vision. So that is his main complaint. And after that, he had a seizure, a frank GTCS lasting for 5 minutes. So in the evaluation of an unprovoked seizure, I got an MRI done. When I look back, this child had a significant perinatal history. So what is the probable diagnosis? What do you see here? This is a T2 sequence, and you have some sort of hyperintensities in the occipital lobe. So this is the medial occipital lobe. So this is important, topography. So there is involvement of bilateral occipital lobe to think about the topography with the pathogenesis. So whenever you have bilateral occipital involvement with significant perinatal history coming to us with seizures later on in life, think about hypoglycemia. So neonatal hypoglycemic brain injury. So NHBI is the diagnosis here. So you have occipital gliosis, you have occipital hyperintensities, and they are often present with occipital seizures. So occipital onset seizures, we have to ask the aura and the seizure onset. They usually have ictal blindness or you have any occipital hallucinations like that. This child had ictal blindness before the seizure. So here another rare cause, this child has come to me at the age of 4 years with neuroregression. The child used to walk till 2 years, and after 2 years he stopped walking. On examination, the child had spasticity, and this is the MRI. What do you think? So here try to identify what is abnormal. So this is a T2 sequence, okay? And I see all the deep nuclei. This caudate is normal, the lentiform nucleus is normal, GP is normal, the thalamus also looks normal. But what is abnormal here? The white matter is abnormally white. So there is T2 hyperintensities in the white matter. So the entire white matter is abnormal. The occipital white matter is abnormal. The centrum semioval is abnormal. And the frontal white matter is also abnormal. So whenever we have a child with neuroregression, with motor regression, spasticity, and T2 hyperintensities like that in the white matter, think of leukodystrophies. So leukodystrophy, when you think of leukodystrophies, again, there are different pattern recognitions in leukodystrophies. Like for example, there is predominant periventricular involvement and centrum semioval involvement. If you see, there is patchy involvement. The perivenular spaces are actually spared. So this is the typical picture, what you see, or what you call as leopard appearance or tigrod appearance. So the most likely diagnosis in this child would be metachromatic leukodystrophy. So this pattern can also be seen in other dystrophies like Krabbe's disease. Okay, thank you.
Yeah.